let's look at some cases. I think these are often more interesting for folks, and so let's look at some of the things that we can do. If there are questions, by all means, put them in the chat. We can stop to chat about them. This is a case where embolization and radiosurgery were used together because it's pretty high priced real estate. So if we actually had you guys up on the screen, I'd quiz one or more of you about what it is we're seeing here, but since we don't, I'll just kind of walk you through it. So here you can see in the upper left, we've got the a lateral projection in ICA. You can see a very large posterior communicating coming back, and off of that is that nidus. Here we've got draining vessels going back into straight Galen. This is now a vertebral artery injection, and you can see off of the posterior choroidal, the LPCHA, the lateral posterior choroidal artery, you see the nidus coming off from that right side of PCA branch. This is what it looks like in lateral, and you can see the nidus broken up into 2 points. This is high-priced real estate. Thalamic AVMs, you can take them out. You're going to hurt the patient. Not worth it. What can we do to reduce the risk of radiosurgery for this kind of a patient? Well, glue can certainly help. So perhaps we can take out at least one of these foci, the nidus, and make the radiosurgical targeting easier. So that's in fact what we did. Going in, we can get into the LPCHA, fill it with onyx. You can see there's dramatic reduction in the filling from that, and then we're able to have a smaller volume. You don't have to worry about targeting all this stuff out back. It's now a much more manageable and feasible target, going from sort of this large oval on the left down to something much smaller on the right, higher dose, less tissue at risk, better outcomes with something like that. Okay, so so those are sort of the, what we're looking to be able to achieve with these combination therapies. Let's look now at the issue of sort of the nidal aneurysm. So this patient comes into you with a ruptured AVM. The question is, what do you do with this, right? The patient needs to be treated in some form or fashion, but how are you going to affect the greatest bang for buck and subject them to the lowest risk? When you look at this angiogram in total, it can be a little difficult to decipher. What we can see is that there's probably a little something over here that's going to draw our attention. If that's actually an aneurysm, that's probably our rupture point. You can probably correlate that on a CTA or an MRA with where the hemorrhage is and see, does this actually make sense with what we think is happening with this patient? Here we can then go in with our microcatheter, go up and selectively embolize that feeding artery aneurysm. We may or may not get the rest of this nidus, but if we've reduced that risk of re-rupture in the short term dramatically by taking out that aneurysm, that's worthwhile. Now we can let the patient cool down, think about what do we want to do with the rest of this? What are the risks? How's the patient going to do from the initial hemorrhage? And that's the advantage of being able to kind of dissect these. Here you can see this is one that we've been able to take a staged approach, gluing over time. And here again is that nidal aneurysm that we were able to glue shut and get a fairly good result. The residual that it may or may not be in high risk territory, maybe that's something that's good for Gamma Knife down the road. And you don't have to deal with it up front because you've taken that risk of hemorrhage sort of off the table up front. All right, so we've kind of talked about all of these things. Let's think about sort of that one of those other kind of rare things that we talked about, but something that can be very difficult. The fistulous connection, where you've got a direct connection between artery and vein. If you look at the angiogram on the left, that is really hard to interpret. There's dye flowing everywhere. It's very high flow, and it can be difficult to understand the angio architecture simply because you can't see well enough. It turns out when you start to micro explore this, that there's a fistula, okay? And you can see here, we've gotten our catheter way out and around and down here, and now we're injecting just through the microcatheter. And you can see even then, when you're just already directly in that vessel, the flow is so high that the dye is just immediately washing out and it's hard to see. What we do in cases like that is we can selectively embolize the fistula, in this case using a coil. So we're not trying to go from 60 to 0, I guess, and shut this off immediately. What we're trying to do is slow it down, right? If you shut it off entirely, sometimes that can increase rupture risk. But by putting a coil in, you're adding outflow resistance. in changing the hemodynamics, it'll likely go away over time. But in the short term, you're at least reducing the risk of it rupturing, okay? And giving yourself a better ability to see. So this is what that fistula now looks like, partially coiled. And now when you do a bigger, global angiogram, you can see sort of how it's put together, the arteries plugging in, the nidus, the vein coming out, and that can help you with further treatment planning, okay? So that's one of the nice treatment modalities. And in this case, they decided to go with radiosurgery, targeting a smaller volume because they were able to kind of see what it is that they needed to target. And knowing what you're targeting is the whole key with radiosurgery.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.